So we will learn about the clinical aspects of anxiety disorder. So starting with the content, what we will learn the Freudian concept of anxiety, fear versus anxiety, or normal versus pathological anxiety, sign and symptoms of anxiety. What are these signs? Terminology in anxiety disorders, epidemiology, etiology, neuroanatomy of anxiety, neurotransmitters involved in originating anxiety disorder, classification of anxiety disorders, and about sign and symptoms of specific disorders and differential diagnosis. So, starting with the Freudian concept of anxiety, Freud in his era gave the concept of libidinal theory. His understanding of psychopathology was based on libidinal theory, which he described it as the increase in sexual tension, which leads to increase in libido, and that tension is relieved by having intercourse as normal outlet. It is also known as instinct or drive theory. So libido he defined as that force by which the sexual instinct is represented in the mind. But libido was not equal to sexuality as per him. Sexuality has a uh, pleasure content, so he defined all the pleasurable uh, instinct as a libido. So, general notion of pleasure and sexuality with underpinning of physiological content represents the mental tension. So we can understand this in next slide. Now, there is physiological increase in sexual tension or any kind of tension which gives pleasure. And there is abstinence or coitus interruptus by virtue of which the person does not relieve the tension, which leads to libidinal blockage and finally leads to anxiety neurosis, neurasthenia, or hypochondriasis. So the term anxiety neurosis first described by Sigmund Freud. So the question is whether the anxiety is normal. It is normal. It is normal in the situation of threat, situation of dangerousness, and if there is any kind of performance pressure which leads to anxiety, and that anxiety leads to flight or fight reaction. If the danger is fatal or so severe that one can fly, or the person is having coping mechanism and understand that he can fight, then he would fight. So normal anxiety is known as fear. Fear is normal and it is a response to a threat that is known to you. You know about the threat. It is external. It is not into your mind. It is in the external environment. It is definite. It is defined that it's a danger and it is non-conflictual. No conflict is there. Then it is fear, like having fear of exams, fear of a speeding vehicle, fear of a barking dog, or similar kind. So this is normal anxiety. It's an alerting signal. It warns of impending danger, enables a person to take measure to deal with the threat, either fight, flight, or freeze. The third one is freeze. One can freeze also. So it helps in enhancing performance, helps one to cope with the changing environment. This is the curve which shows if the anxiety or level of stress is medium, then the performance is optimal. As I have explained, the person who has lower or minimal level of anxiety, he won't perform that much. Or either if he is having severe anxiety, also the performance is decreased. Now the question is when the fear becomes pathological anxiety. When anxiety is a response to a threat that is unknown, the threat which is not known to you, it is internal into your mind, it is vague and it has conflict, then this is pathological anxiety. When it becomes excessive, it becomes disabling and stumbling block in day-to-day functioning. It is severe and persistent. One can have a severe anxiety for a moment of time, and this does not mean the person is having anxiety disorder. If it is severe and it remains persistent, then only it is disorder, and it has impact on personal and or social functioning. Now, sign and symptoms of anxiety can be divided into three parts: cognitive, biological, and behavioral. The cognitive symptoms can also be said like central symptoms, and it pertains to thinking of the person. For example, dread and apprehension about the future, if one is having in his mind, or they will think like, I will do something wrong, I will commit mistake, I cannot do this work, who will help in this work, and others will recognize that I am frightened. A feeling of impending heart attack may be there, and anticipatory anxiety. Anticipatory anxiety is anxiety of having attack of anxiety. This is anticipatory anxiety. The bodily responses are can be considered as peripheral symptoms are diarrhea, hyperhidrosis, hyperventilation, palpitations, restlessness, tingling, coldness, tremors, upset stomach, and urinary urgency, frequency, or hesitancy. What will be the behavioral symptom? One has a cognition of anxiety, then he developed bodily symptoms. Now, how he will behave in by virtue of this anxiety? The person may have agoraphobia. He may relieve anxiety by avoiding the stimuli, or relieve anxiety by performing rituals which are known as compulsions. He may uh, acquire moping behavior, that is the need or desire to be alone with your own thoughts and try to deal with your anxiety without the help of others. Unhealthy coping tools may be there. This behavior like substance abuse, uh, nervousness, you can see like shaking your leg up and down, touching your face, winking or blinking. These are the physical behavior. The behavior can be thought behavior also, like negative self-talk, that is I am going to embrace myself, feeling as though you are going crazy, convincing yourself something is wrong with you. These are the thought behaviors. Now the terminology, uh, you have heard the word anxiety, fear, phobia, and panic attack. What are these term means? You know about the anxiety now, the sign and symptoms of anxiety. What are anxiety disorder? So anxiety disorder are episodic or continuous anxiety not because of the organic mental disorders or physical disease. A panic attack are having severe anxiety with a feeling of impending doom or losing control or going mad. What is phobia? Phobia is anxiety and which is associated with avoidant behavior. The fear the response to known, external, definite, and non-conflictual stimuli. So keep in mind these terms. Further, we will discuss about the disorders. Now, few words about the epidemiology. This is one of the most common groups of psychiatric disorder, and the prevalence is almost equal to depressive disorders. The globally it is present in 3.8% people, and in India it is 3.3%. National comorbidity survey, which is one of the largest survey, reports that one of four person met the diagnostic criteria for at least one anxiety disorder. The 12-month prevalence is 17.7%. Women are more affected than males, and it decreases with higher socioeconomic status. Okay? Now the etiology. The etiology in psychiatric disorders, for almost all psychiatric disorders, are best defined by this model: bio, psycho, and social. There is no one entity is causative factor of psychiatric disorder, and so for the anxiety disorders. These are the biological factors, psychological factors, and social context or social situations. So we will go through the etiology from all the three point of view. Now first discussing the psychological point of view. Psychological variables that predict vulnerability to anxiety are perceived control, second is cognitive appraisals, cognitive beliefs, and cognitive distortions. What are perceived control? Okay. The childhood experiences can heavily influence the someone's perceived sense of control. How they are treated, how they are reared, what kind of environment was there in the family, how was the communication style in the family. All these things impact on a child for developing anxiety. For example, overly protective parenting style can communicate the world is a dangerous place. A child who is overly protected uh, for a long period of time, like up to 12th class, and then he will go to a college, and he have to do all the things on his own, and at that time the person or the child is not able to cope up with the demand of society. So this can be harm of a overly protective family. Okay. Similarly, underprotective or low care style family also result into unstructured, chaotic world filled with the stress. Similarly, loss of parents, separation from primary caregivers can lead to anxiety disorders. A third type of experience is ongoing trauma, such as childhood abuse, like physical, emotional, or sexual, may also lead to psychiatric. Now, cognitive appraisal. This means the way we evaluate and assess a particular situation. This can be primary or secondary. In primary, this refers to an individual's subjective evaluation of situation, and in secondary appraisal, the ability to cope with that situation. Whether the person is understand the situation, and he also understands that he will be able to cope with that situation. This is cognitive appraisal. Now, belief can also contribute to psychiatric disorders like anxiety disorders. So, belief is something one accepts as true or real, also untrue or unreal. Some can agree with the one uh, thought of a school, some other may not. Some think that this is yes, as some may say this is not as such. So this is belief system. So the system of belief having some unhealthy beliefs such as these beliefs can be the person may think like it is true that there is something wrong with me. It is true that it's my fault for making others upset. It is true that children should be seen and not heard. A child can think like that when parents are doing uh, such a behavior. It is true that it is wrong to express my opinion. It is true that I have to be very concerned about what other thinks of me. It is true that I am never going to be a good enough or a good person. So after belief, the cognitive distortions like catastrophizing, the example is there. If I fail this test, I won't be good at my career. This may be cognitive distortion. I know we are all going to get fired soon and everything is going to go downhill. And in dichotomous thinking, any reason that begins with the word always, never, all or nothing, the person remains in the white area, either white area or in the black area. He does not believe in the gray scale. You must have learned about the all and none phenomena in physiology. Either it is all or it is none for him. Selective abstraction, like for example, someone feel like I invited everyone in the office to my birthday party and Swati didn't show. I am sure she hates me. So these are the cognitive distortions. Reason may be others also, but he thinks like that. My boss is arguing with someone in the office. It is probably due to something I did wrong. So now contribution of behavioral sciences. So you all know about the classical conditioning. You must have uh, read in your physiology books, classical conditioning, the theory given by Ivan Pavlov. So the theory of Ivan Pavlov was theorized by Watson and Morgan that that it is account for much emotional behavior in the humans. The theory is not a mechanical theory; it has emotional connotations also. No, the behavioral or learning theories of anxiety postulate that anxiety is a conditioned response to a specific environmental situation. For example, if one has severe anxiety in a lift, you know, so he will, and it occurs somewhat repeatedly, then he make out that the lift, the closed one thing is the causative for my anxiety. So the person may avoid that situation, may not go into the lift uh, for elevating. So there is an example in a model of classic conditioning. A girl has panic attack while traveling, and for example, may become anxious as soon as she has to travel for somewhere. You know, if she would have been uh, travel to somewhere alone, she will feeling anxious without exposing to the situation. Okay. So this is classical conditioning. And what happens in operant conditioning? Operant conditioning is a behavioral principle that refers to learning that occurs because we experience either reinforcement or punishment. For example, we have done something, you know, and we got a positive reward for that doing. So we will reinforce to do that work again and again. If we got the punishment, then we will avoid or not try to do the thing in the future. This is operant conditioning. The difference in classical and operant conditioning basically is in classical conditioning, it is a passive phenomena, and in operant conditioning, it's an active. You are doing something and you are getting reward or punishment. So this is an act. So last one is the existential theory. which applies for generalized anxiety disorder. Uh, in this, there is no specific identifiable stimulus exists for a chronically anxious feeling. The central concept of existential theory is that person experience feeling of living in a purposeless universe. So these were the psychological and behavioral contribution about the anxiety. Now, what are the biological? We will go through the neuroanatomy, neurotransmitters, autonomic nervous system, brain imaging studies, and genetic studies. Starting with the neuroanatomy, look at this picture. There is a central figure called as amygdala, and others are anterior cingulate gyrus, orbitofrontal cortex, hypothalamus, preaqueductal gray area of brainstem, locus coeruleus, parabrachial nucleus, and hippocampus. We will learn one by one about this neuroanatomy. In this neuroanatomy, the central figure is amygdala, which communicates with all these areas. Uh, Now look at the first. Amygdala communicates with orbitofrontal cortex and anterior cingulate gyrus, produces fear affect. It produces the emotional part of the anxiety. When amygdala communicates with preaqueductal gray area of brain stem, it creates motor response like fight, flight, or freeze reaction or avoidant behavior. When it communicates with hypothalamus, there is endocrinal response to HPA axis, which leads to increased cortisol level. You all must know about the HPA axis in the physiology. Now how it is related to the psychiatry also. This is the HPA axis. Amygdala uh, give positive feedback to hypothalamus, then to pituitary, then to adrenal gland, and then it releases cortisol, which gives the negative biofeedback to the system of HPA. When amygdala communicates with parabrachial nucleus, it leads to increased respiratory rate. You must have seen that in anxiety, respiratory rate is increased. This is because of this communication. Locus coeruleus, the communication with amygdala cause autonomic hyperactivity. Now we will learn what is symptoms of autonomic. These are the symptoms: dilated pupils, inhibited salivation, increased heartbeat, relaxed airways, inhibit activity of stomach, stimulate release of glucose, and inhibits gallbladder, inhibits activity of intestine, secrete epinephrine and norepinephrine from the adrenal glands. It relaxes bladder. Uh, why? Because of this, frequency, urgency, or hesitancy is noted, and it promote ejaculation and vaginal contraction. So these are the signs and symptoms of autonomic hyperactivity. So this is the anxious facies. So you can see the wide palpebral fissure, frowning on the forehead, open mouth. So you can relate this lady is anxious, and this image is generated by AI. You know, the Binge has incorporated Dela E software. So I have generated this anxious faces from that software, artificial intelligence. When amygdala communicates with hippocampus, it triggers anxiety because of internal memory, and this communication relates with the post-traumatic stress disorder. What happens in post-traumatic stress disorder is when the person relives a traumatic event in the past, he think of or he reliving the trauma, so he gets the anxiety. So this is the internal memory which triggers anxiety. So in brief, Uh, Anterior cingulate cortex, orbitofrontal cortex leads to fear affect or emotion. Preaqueductal gray area of brainstem leads to motor response. Hypothalamus leads to endocrinal response on HP axis or increased cortisol level. Parabrachial nucleus leads to increased respiratory rate. Locus ceruleus leads to autonomic hyperactivity, and hippocampus leads to anxiety triggered by internal memory. Now coming to the neurotransmitters which are involved in this uh, neuroanatomical structures. So when it is amygdala centered circuit, these uh, neurotransmitters are involved. The first one is serotonin, then GABA aminobutyric acid, glutamate, cortisol, corticotropin releasing factor and HPXS, norepinephrine, voltage gated ion channels. These neurotransmitters are involved and which leads to fear, panic and phobia. There is another loop which is known as worry loop. It is cortico-striato-thalamocortical loop. It also involves the all similar neurotransmitters uh, other than CRF, which replaces by the dopamine DA. These neurotransmitters are involved in genesis. So I will explain only the serotonin transmission. You can look at this picture. On the upper part you have pre-synapse, and in the lower part you have post-synapse, and the area between these pre-synapse and post-synapse is synapse. So you can see the bubble-like structures. These are vesicles which are having serotonin and released into the synapse. And these orange tubules are SERT transporter, which takes back these vesicles into the presynapse if it remains unused. And this triangular structure is autoreceptor, which regulate the release of uh, serotonin vesicles into the synapse. And in post-synapse, these are the trapezium-like structure are post-synaptic receptors, activation of which leads to uh, activation of a cascade system which activates second messenger and generation of protein kinases and the expression of genes. So this is the transmission of serotonin in synapse. So now few words about the brain imaging studies. Computed tomography and MRI occasionally show some increase in the size of cerebral ventricles. These are the findings. These are not the uh, cannot be said as causative factor for anxiety disorder, but on MRI and imaging, these features have been noted and seen. The functional MRI, PET, SPECT, and EEG of patients with anxiety disorder have variously reported abnormality in frontal cortex, the occipital and temporal areas, and in a study of panic disorder, the parahippocampal gyrus. And the caudate nucleus is implicated in the pathophysiology of OCD on this functional imaging. So this is few points about the genetic study. Almost half of all patients with panic disorder have at least one affected relative. A higher frequency of illness in first degree relatives of the affected patients than the controls. Data from twin registries also support the hypothesis that anxiety disorder are at least partially genetically determined, and low anxiety disorder is likely to result from a simple Mendelian abnormality. Now coming to the classification, look at this slide. This gives the ICD-10 classification of anxiety disorder, and the highlighted one we will discuss further in the slides. Okay. So the first one is agoraphobia, with or without panic disorder. Okay. The other is social phobia, specific or isolated phobia, panic disorder, generalized anxiety disorder. So these are the symptoms of anxiety or worry. You can see this slide is somewhat faded. Okay. So first one is one can have fatigue, one can have hyperarousal, one can have panic attack, one can have avoidance, one can have compulsions, muscular tension, irritability, sleep problems, and impairment in concentration. So these are the overall symptoms, but all the disorders does not have all these symptoms. The disorder have a theme, and on the basis of that theme, the person is having symptoms out of these. So starting with agoraphobia, with or without panic disorder. Agoraphobia is fear of being in those places from where easy escape is not possible. The place is open, the place is not closed. The person uh, have anxiety in these places, uh, thinking that easy escape is not possible from this place. It may be associated with panic attack. You already know the repeated acute intense attack of anxiety accompanied by feeling of impending doom. The feeling of impending doom must be there. Impending doom, going mad or losing control must be there to say it's a panic attack. Otherwise, it's a anxiety. So this is the diagnostic guideline of ICD-10. Uh, there must be the psychological or autonomic symptoms uh, primarily manifesting the anxiety and not secondary to other symptoms such as delusions or obsessional thought. The anxiety must be restricted to at least two of the following situations like crowd, public places, traveling away from home and traveling alone, and accompanied with avoidance of the phobic situation may have the prominent feature. So now look at the yellow part. What happens in panic disorder, there is a central theme of anticipatory anxiety, and there are panic attacks and avoidant behavior in form of agoraphobia. So these are the symptomatology of panic disorder with or without agoraphobia. Now coming to the social phobia. In social phobia, there is marked fear of being the focus of attention. Uh, when one is giving the speech or giving the lecture, the person is in the focus of attention, so he may have anxiety at that point of time. It is social phobia. The second point is marked avoidance of being the focus of attention or situation in which there is fear of behaving in an embarrassing or humiliating way. The biological symptoms are blushing, fear of vomiting, urgency, fear of micturition or defecation. Rest are these. So now look at the again at the yellow part. There is the central theme is performance anxiety or worry about exposure, and there are panic attacks and avoidant behavior to that social situation. The agoraphobia is fear of being in places from where easy escape is not possible, and the avoidant behavior in social phobia is to the situation which are causing social situations which are causing specific phobia. As the name defines, it is the phobia of specific situation or object, like particular animal, height, thunder, darkness, closed spaces, sight of blood, or etc. So, in specific phobia, the central theme is specific anxiety and avoidance to that specific situation. Now, generalized anxiety disorder, the essential feature of anxiety which is generalized and persistent. It is not specified, it is generalized to all of the things or most of the things happening in the life or in and around in the near future or in the near past. This is not specific, so it is called as free floating anxiety. Anxiety is free floating. This is the diagnostic criteria. In generalized anxiety, you will have almost all of the symptoms, other than panic attacks, avoidance, and compulsions. The person may be hyperarousal, may feel fatigue with impaired concentration, disturbance of sleep is there, irritability is there, and muscular tension. So this is about the anxiety disorder. So we have learnt about the panic disorder with or without agoraphobia, social phobia, specific phobia, and generalized anxiety disorder, and panic disorder as a part of agoraphobia with panic disorder. So what are the differential diagnoses for anxiety disorder? Other psychiatric disorder may have anxiety also, like depression, substance abuse, and psychotic illnesses like schizophrenia can also have anxiety. So you have to rule out whether the person is having a primary psychiatric disorder or not. 90% of time, depression present with anxiety. Other than psychiatric disorder, there is a exhaustive list of physical disorders which may lead to anxiety, like almost all of the systems are involved, like cardiovascular system, like anemia, hypertension, angina, in pulmonary disease, asthma, embolus, hyperventilation. Neurological disorders can also have anxiety. Endocrinological disorders like Addison's disease, Cushing syndrome, diabetes, hyperthyroidism can have anxiety. Drug intoxications can also have symptoms of anxiety like amphetamine, amyl nitrate, anticholinergics, drug like cocaine, uh, hallucinogens, marijuana, nicotine, theophylline. These all can create anxiety. Drug withdrawal, like withdrawal of alcohol, withdrawal of antihypertensive, opiates, and sedative hypnotics can also lead to anxiety disorder. Other conditions like vitamin B12 deficiency, anaphylaxis, and others like electrolyte disturbance, heavy metal poisoning can also have anxiety. This is not the last list. The list is more exhaustive. So when you are dealing with the patient with anxiety, so you should be cautious about these physical disorders also. The person may have pheochromocytoma, severe hypertension, or cardiac illnesses, which may lead to anxiety and confused with the anxiety disorder. So this is the last and thank you slide. Thanks for patient listening. So we will recap what we have learned is the Freudian concept of anxiety, fear versus anxiety or normal versus pathological anxiety, sign and symptoms of anxiety in terms of cognitive, uh, biological and behavioral symptoms, terminology like panic, anxiety disorder, panic attack, fear and phobia, epidemiology, etiology, classification of anxiety disorders, uh, and clinicals of specific disorders and differential diagnosis. So these things we have learned today. And what is next in the lecture is the management of anxiety disorders. Okay.